So welcome everyone to our education session this evening on abortion care and update for primary care providers. I'm Jo Silver, I'm the GP at Western Health, and with me tonight we have our speakers, Dr. Etka Neal and Carolyn Mockabell from 1-800 Options. And behind the scenes we have the wonderful Yvonne, who's helping with all the tech support and also has helped with our registrations and CPD this evening. All right, next slide. So I'll begin with acknowledgement of country. Western Health and Northwestern Melbourne Primary Health Network would like to acknowledge the traditional custodians of the land on which our work takes place, the Wurundjeri Woiwurrung people, the Boon Wurrung people and the Wathaurong people. We pay respects to elders past, present and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Next. So as you all know, we're here on a Zoom meeting and hoping for the best with all the technology. Everyone's muted. And can I just ask that you put your questions in the Q&A box only, so as then we'll be able to go through them at the end of the session. If there's anything really pressing, I'll pop in and interrupt the speakers just to get some clarification if we need. The session is being recorded, so which is great. If you miss anything, you'll be able to go back onto the PHN site and watch it later. And in the next week or so, Yvonne will send out a link to the recording and the copy of the slides and any of the resources. So just ensure that you are registered, or the name on your screen is showing the name that you've registered with. So Yvonne won't be able to work out who you are if it's Dan's iPhone or something. So if that's the case and you're not sure if your correct name's coming up or you can't change it, then just please send Yvonne a message in the chat function and tell her who you are. So as that way she'll mark you as attending and ensure you get your CPD points. So like always, we're just going to give you a little bit of update on Health Pathways Melbourne and where you can find some additional information on abortion care there if you are struggling at any time and need some extra updates. So next slide. So the pathways, as you know, are written by GP clinical editors with support from local GPs, hospital-based specialists and other subject matter experts. And they give you a guide on assessment, management and how to refer, and links to various services that are available, and lots of resources that you can use for your patients. So next slide. There is specific pathways on women's health and the early medical abortion. So you can just log on to the pathways and take yourself there if you need any updates or support. There are many pathways on how to access termination of pregnancy, both medical and surgical terminations, and then also some pathways on some of the issues that you may see in early pregnancy, so bleeding, pregnancy genetics, prenatal screening. And if you review any of the pathways, you can record your CPD hours spent. So you can click on that button there for CPD hours and it will take you through to the next slide. So it'll allow you to record your CPD, which is really helpful as well, because I think a lot of us aren't very good at recording any of the sort of that informal reading that we do, journals and things, but we're often doing that on a regular basis, but just not telling anybody. So most of us will have access to Health Pathways Melbourne. If you don't, then you can send an email to the Pathways team or scan that QR code there on the screen and get access. Save your password, because we all now have individual logins, and then you'll be able to access that easily from your desktop at work. All right. So now on to our speakers. So we have two speakers, like I said, this evening. First speaker is Dr. Etka Neal. She's an obstetrician gynecologist at Western Health. and she's been working at Western for over 10 years as is the medical lead of its abortion service since its inception in November 2023. Etka also works in the abortion and contraception service at the Royal Women's Hospital and in private gynecology in Melbourne's West. And our other speaker is Carolyn Mockabell, who's the manager of 1800 My Options. So 1800 My Options is Victoria's phone line for contraception, abortion and sexual health at Women's Health Victoria. Carolyn has over 15 years experience in health promotion and service delivery with a focus on equity of access to sexual and reproductive health services for marginalised and underserviced communities. So over to you, Etka.
Thanks, Jo. And thank you for the invitation to speak today about a topic that I am very passionate about. I am going to start with a case presentation. And so patient DP is a 36-year-old. She's a Gravida 3 Para 2 who presents with 6 weeks since her last period and a positive urine pregnancy test. She has no significant past medical or surgical history, has had 2 previous vaginal births, and this is an unplanned pregnancy. She was using the withdrawal method for contraception. Adding to DP's case is that she is from a non-English speaking background. Her youngest child is only 8 months old and she's still breastfeeding, and she's not working and has significant financial constraints. She never thought she would do this and she feels ashamed, but she's asking about a termination as she is not ready to have another child. Case 2. CM is a 32-year-old Gravida 1 Para Not who presents of unknown gestation, but thinks her last period was a couple of months ago. She has a 10-year history of ice use and has been clean for the past 8 months. Her supportive partner has just regained custody of his 7-year-old daughter, and she is currently homeless and couch surfing between friends, but has recently gotten a volunteer position with the Country Fire Service. She had a blood test and her beta HCG is 12,000, and she was told that she was probably about 6 to 7 weeks pregnant and given a request slip for an ultrasound. She feels like she's just getting her life back on track and is not sure if she's ready for a pregnancy. And both of these patients are patients I've seen within the last month. As I go through this presentation, some questions to consider are: what would be your next steps? Where would you refer them for options counseling if needed? And what barriers do these patients face in seeking care? And from a bit more of a clinical point of view, are they suitable for medical or surgical termination? How and where would you refer? And how would you manage any potential retained products of conception following a medical abortion? I'm going to start with an introduction and then provide some clinical updates, practical tips, and then talk a little bit about local services, although Carolyn will go into that a lot more after. And then just come up and wrap up with what's happened with these 2 women. Abortion is defined as the intentional interruption or termination of an ongoing pregnancy which is not intended to result in a live birth, usually with medical or surgical intervention. This is an essential part of reproductive and women's healthcare, as the decision of when to get pregnant, give birth, and become parents has many implications. According to the World Health Organization, lack of access to safe, timely, affordable, and respectful abortion care poses a risk to not only the physical, but also the mental and social well-being of women, girls, and pregnant people. We also know that young people and marginalized groups, including First Nations, people of color, those living in economic poverty, and sexual and gender minorities are more likely to be harmed by abortion restrictions. Restricting access does not reduce the number of abortions, but it dramatically affects whether the abortions obtained are safe or not. And we can see this happening in other parts of the world. Unsafe abortions are one of the main causes of maternal morbidity and mortality globally. By offering safe care, prompt follow-up, and access to contraception, abortion-related deaths and morbidity can be greatly prevented. I'd like to acknowledge that there are varying beliefs amongst our patients and even between those of you attending today in terms of your thoughts around abortions and providing abortion care. It's important to acknowledge different cultural attitudes towards termination and the importance and sensitivity of care. I think we've got a bit of a varied audience, but most are GPs. And I'm not sure about you, but I know that when I went through medical school, abortion was not something that was taught. And even as an obstetrician gynecologist, I actually had to seek out 6 months of advanced training to actually feel comfortable providing this care. So it's something that really hasn't been mainstream medical care, although that is starting to change, fortunately. The other thing I wanted to discuss is the terminology that we use. We actually went back and forth a couple of times about the title for this talk, but abortion care and providing abortions is the correct medical term. By not using that word, we are actually increasing stigma. Furthermore, this is the wording that patients use and that patients know. Hospitals have fracture clinics and seizure clinics, but we don't tend to call them abortion clinics in hospital. If a patient's trying to seek care, they don't search, how do I get a choices, or how do I get, even determination is not as common as where to get an abortion. There's also some stigma around the reason for seeking an abortion. There tends to be more sympathy and favored responses to patients who have a very wanted or desired pregnancy that unfortunately is complicated by a either genetic or fetal abnormality that results in requirement for a termination. And those patients tend to be, it's a very unfortunate and sad circumstance, but they tend to be viewed more favorably than the woman who is unable to afford to feed her 3 children, or the other patient who's trying to flee family violence. And so all the laws across Australia, the reason for abortion is not required. A woman is not required to give a response, but rather to be supported in the choice that she makes that's best for her in her current circumstances. And that comes back to the choice. As an abortion provider, I'm not pro-abortion, I'm pro-choice. And it really is about supporting women to make the best decision for them at their current stage in their life. The other thing I'd just like to mention is I've often gotten asked, you know, do you make your patients go through counseling and things? Obviously, this is a very big decision, and options counseling needs to be accessible and offered to patients who require it. But it's not routinely offered to women who choose to have a pregnancy or continue a pregnancy. 40 to 50% of pregnancies in Australia are unplanned, and we don't ask pregnant women to go through counseling. And I would just comment that the decision to parent is quite a significant life-changing event as well. We also know that surgical abortions, especially in the first trimester, are much safer than pregnancy and childbirth from a medical risk point of view. The government of Victoria introduced the Abortion Law Reform Act in 2008. And what it says is a termination of pregnancy at under 24 weeks can be performed by a registered medical practitioner. There are also provisions for beyond 24 weeks. This is the actual law. I'm not going to go into all of it. But essentially what it says is the patient has to be consulted by 2 doctors, and they have to agree that it's appropriate in all circumstances, which are the women's medical circumstances, but also her current and future physical, psychological, and social circumstances. Although this is what the law says, what actually is accessible is very different. Abortions beyond 16 weeks are only really accessible at the Royal Women's Hospital in Melbourne. And beyond 20 weeks, a very limited number of abortions are accessible. 90% of abortions in Australia are done in the first trimester. There are also provisions in the law for conscientious objection. And essentially it says that if you are a conscientious objector, you need to inform the women, but most importantly, you must refer to another registered health practitioner who you know does not have an objection. There's also provisions in the law that you cannot decline care in an emergency or life-saving situation. Abortion restriction causes harm. The Turnaway study is a prospective study in the US that examined 1,000 women and the effects of an unwanted pregnancy on their lives. They looked at the mental and physical health and socioeconomic consequences of either receiving an abortion, versus being denied an abortion and carrying an unwanted pregnancy to term. The main finding of the Turnaway study is that receiving an abortion does not harm the health and well-being of women, but in fact, being denied an abortion results in worse financial, health, and family outcomes. Specifically, it creates economic hardship and insecurity, which lasts for years. Women were less likely to have aspirational life plans for the coming year if they had been denied care. It means women are more likely to stay in contact with a violent partner and to raise the resulting child alone. It negatively impacts the financial well-being and development of children, including for existing children in the family. It can also lead to more serious health problems than giving birth, including pregnancy complications such as eclampsia or death, although very rare. But women who were denied an abortion were more likely to have chronic pain in the future. There are two different types of abortion, medical and surgical. An early medical abortion, which is also known as MTOP, involves MS2-step, which is two medications, mifepristone, an anti-progesterone, which is taken orally, followed 24 to 48 hours later by buccal misoprostol, which is a prostaglandin analog and induces uterine contractions and softens the cervix. It is safe and can be used for most women and has an efficacy of 94 to 95% roughly of a completion rate and a failure rate of 1%. It does require follow-up to ensure that the abortion is complete and that the beta HCG has dropped. It's essential that patients have a clear explanation of pain and bleeding. The average time of bleeding following an early medical abortion is actually 16 days and can be up to 4 weeks or until their next menstrual period. And that's why establishing expectations is essential. It's also really important to distinguish between troublesome bleeding and pathological bleeding in the weeks following. Retained products of conception management is really based on a clinical diagnosis. It's unless a patient is very unstable or they have suspicions of abnormal bleeding or an ongoing pregnancy, it's generally recommended to avoid an ultrasound within 2 weeks, as blood clots, debris, or thickened endometrium are common findings and are unlikely to actually guide clinical management. It's important to assess for signs of infection and treat accordingly. And if the patient is continuing to have persistent bleeding beyond that 2 weeks mark, heavy bleeding, or if you are concerned that they had very limited bleeding with that initial medication, that might be concerns for an ongoing pregnancy and a repeat ultrasound is warranted. If retained products of conception are confirmed, management generally is expectant or medical, and medical can be given with a repeat dose of misoprostol. Surgical management is recommended if the patient is hemodynamically unstable, has evidence of an infection, or if they have unacceptable heavy bleeding. The Royal Women's Hospital has really good clinical pathway guidelines, and the link is there, and it will be available to you in the slides and even in the resources after. A surgical abortion is a procedure that requires a trained clinician in an approved medical facility. It requires investigations prior, and patients can have a concurrent contraceptive device inserted. In the first trimester, it's a suction D&C, which is similar to management of a miscarriage. Beyond 14 weeks, it's a dilation and evacuation. This procedure requires preoperative preparation and a surgeon with appropriate training, and this is why access tends to be limited beyond this gestation. RANZCOG in 2023 published the Clinical Guideline for Abortion Care, which is a binational evidence-based guideline in people providing abortion care. And that is also available for free online and can be accessed. Some updates to care and things that have changed recently. MS2-step for early medical abortion, or MTOPS. As of July 2023, the requirement for certification was removed, and it can now be prescribed by any healthcare practitioner with appropriate qualification and training. And in the recent RANZCOG guidelines, some of the changes are that anti-D is no longer required for a termination of pregnancy under 10 weeks, and that's whether it's a medical or surgical abortion. RANZCOG also has published a decision-making guide to help patients decide between medical or surgical abortion and what would be suitable for them. And that's accessible through Health Pathways as well. They've also stated that it is required to establish the patient's gestational age prior to abortion, but have not gone so far to say that an ultrasound is required. And so they've actually removed the mandatory requirement for an ultrasound. That's something that causes quite a bit of discomfort, especially some of my ONG colleagues. And so what they have mentioned is to determine gestation, we need a good clinical history, and to assess the patient clinically, whether they have symptoms or signs of an ectopic pregnancy, or if they have risk factors for an ectopic pregnancy or a previous history of such. The decision then of whether or not to get an ultrasound, if they have clear dates and no risk factors, would depend on the patient preference and their available resources. It's also essential that these patients do have follow-up. And if there's any uncertainty, we need an ultrasound to confirm whether or not this is an intrauterine pregnancy. Now, this is actually supported by some literature in the last 5 years. So the British Journal of ONG in 2021 has published a report on the no-test medical abortion. Probably one of the few benefits of COVID was they moved from an in-person abortion care to a telehealth model. In the UK, the British Pregnancy Advisory Service, or BPAS, they actually provide 85% of the country's abortions, so they have large numbers. They looked at about 20,000 patients in the old model, so the face-to-face model, and then for about 30,000 patients in the newer telehealth model. What was really essential for them was they had a very clear screening protocol to assess gestational age and whether or not there was any risk of the patient having an abnormal pregnancy. 60% of patients were deemed suitable for a no-test abortion, so proceeding without an ultrasound. And what they found was that there was no difference in complication rate or abortion success rate, but patients in the telehealth model received care earlier. I think one of the really important things to take from that study is 60% of the patients, so 18,000 patients in that 30,000 cohort, received a no-test abortion. But 12,000 patients, or almost 40%, still required an ultrasound. And so as long as there is very careful screening, this is safe. But by no means are we advocating to just do this for everyone. Similarly, last year in the New England Journal of Medicine, a randomized control trial was published. It was done across 26 centers. It was multinational. And they looked at patients who were less than 6 weeks gestation, so up to 42 days. All patients did have an ultrasound, but that ultrasound did not confirm an intrauterine pregnancy. So either it was a PUL, or pregnancy of unknown location, or they had a small sac, but no yolk sac or fetal pole to confirm that it was a true gestational sac. In that group, patients were then randomized to either receive a follow-up scan a week later or to proceed with an early medical abortion. They also found no significant difference in complications or success rates of the medical abortion. They also had careful screening criteria and looked to correlate the ultrasound findings with beta HCGs. And so if beta HCGs were inconsistent with their stated gestational age, they had a gynecology review either. And so my take homes for this is that it is suitable in certain circumstances to not do an ultrasound, but it's very important then to have appropriate screening for both gestational age and risk factors and symptoms for an abnormal pregnancy if they're not having an ultrasound prior, and also essential for them to have follow-up. There are a few centers in Victoria that are doing this, Sexual Health Victoria, and they have a very clear protocol to ensure that they're maintaining safety. Some practical tips. One thing that I have seen quite a bit actually is patients who are given incorrect gestation estimates based on their beta HCG levels. And so we know the beta HCG level climbs at the beginning of pregnancy, peaks around 9 to 14 weeks, and then starts to decline. Unfortunately, that means a beta HCG level might be 6 to 8 weeks, or it could also be 16 to 18 weeks as they're on the decline. And this brings us back to that case I presented at the beginning, who had multiple psychosocial issues and had a blood test with a beta HCG of 12,000, who was advised she was probably 6 to 8 weeks and told to get an ultrasound. And we'll come back to her earlier, but it just goes to show that we cannot use beta HCGs to actually date a pregnancy. We need an ultrasound for that. When seeing patients, it's very important to have open, non-directed questions. Was the pregnancy planned? How do you feel about the pregnancy? There's also key differences between conscientious objection versus obstruction. I've seen more than one referral come through saying, I couldn't convince her to continue the pregnancy. And that kind of language causes obstruction in patients seeking care, especially if they're seeing a doctor that they have such a good relationship with. If they're then feeling judged by accessing care, it often results in a delay in them actually presenting for further care. The other example here is, why don't you just go have these tests and see if everything is normal and then come back in a week or two to review everything. Again, that further delay can mean the difference between a first and second trimester abortion. There's a few different options for options counseling. If you're a credentialed GP, there's actually an MBS item number for this. And I reckon there's quite a few of you on the audience who probably know more about that than I do. And there is an online free course available through GP Learning if this is something that you're interested in providing. 1-800-MY-OPTIONS is a very good resource to go to in terms of finding an options counselor. And the Centre of Perinatal Excellence and Melbourne Pregnancy Options Counsellors are some other local providers that would be able to provide options counseling. There's also some online decision-making guides to help a patient when they're unsure if they want to continue the pregnancy, possibly have adoption, or have a termination. The Royal Women's Hospital has some resources for this available through the link, and Children by Choice in Queensland also has a good online resource for that. That was not meant to happen. Sorry. In terms of local services, I have no affiliation with the Northern, but they do offer surgical and medical abortions up to 13 weeks and 6 days. I work at the Royal Women's Hospital. We do have priority criteria to prioritize patients from more vulnerable backgrounds. Early medical abortion is offered, and surgical abortion is available up to 23 weeks and 6 days, although there is very limited capacity beyond 20 weeks gestation. We also have a pathway for post 24 weeks for patients in extenuating circumstances. As mentioned at the beginning, we started the surgical abortion service at Western Health in November of 2023, so it's been about a year and a half now. We're providing surgical abortions up to 15 weeks and 6 days presently, and we provide a weekly same-day service. So patients have an intake call with the nurses prior, and then they're seen on the same day for a medical consult in the morning, and then their surgery that afternoon. We're able to provide this service for 5 patients a week. We do currently require a GP referral and an ultrasound prior so that we can ensure dates are correct. And we also have criteria to prioritize patients from vulnerable backgrounds. In March of this year, we have also commenced providing early medical abortions up to 9 weeks and 0 days. This is provided through the Women's Health Hub at Sunshine Hospital and is actually GP-led. There's also the Melton Sexual and Reproductive Health Clinic, which is run by an endorsed midwife who is able to prescribe early medical abortions. This clinic does not require a referral. Patients can actually self-refer by clicking on the link provided here. This is directly from Health Pathways. And so just in terms of how to refer, it's essential that results are attached to the referral, but also that the patient is directly given copies as well, so that it can prevent delays in accessing care. to refer to Western Health. Referrals with the ultrasound and any other investigations can be sent through fax or email as listed here. Our nurses also carry a mobile phone during business hours. And so if you yourself has any questions, or we're happy for this number to be given to patients as well, so that they're not facing more barriers or more difficulties in accessing care. So we're happy to talk to them as well. For early medical abortion, we have no criteria and are happy to see anyone. For patients who are after a surgical abortion, we do try to prioritize patients from more vulnerable backgrounds, and these are our eligibility criteria here. And as mentioned, the slides will be available. Wrapping up now and coming back to these two cases. So the first patient had two young children and was 6 weeks pregnant. She had an ultrasound that also confirmed an intrauterine pregnancy, and then had an early medical abortion with her local GP. She presented 2 weeks later with persistent spotting, but had no pain, and her beta HCG had fallen appropriately. Reassurance was provided, and she had an implant on for contraception. And her bleeding settled 10 days later. Patient CM, she thought she was still early and still had time, and due to her multiple competing priorities in life at the moment, had her ultrasound 4 weeks later when she was found to be 20 weeks gestation. She was requesting an abortion as she had decided she was not ready to parent, and in fact, finding out her late gestation reinforced that decision for her, and she declined further options counseling. She was referred to the Royal Women's Hospital and had a surgical abortion and Mirena insertion. And that is it. So I will now stop sharing and hand over to Carolyn. And I think we'll take questions at the end unless there was anything pressing.
Hi, folks. Thanks so much, Hector. Fabulous as always. Now I'm just going to get my slideshow working. Bear with me a minute, folks. All right. All right, here we go. So my name, thanks everyone. My name is Carolyn, and I'm the manager of the 1800 My Options service at Women's Health Victoria, which is Victoria's phone line for contraception, abortion and sexual health. We're funded by the Victorian state government. I'd also like to acknowledge that we are on, I'm on the land of the Wurundjeri people of the Kulin Nation today, and I'd like to pay my respect to Aboriginal people that may be present today, as well as their elders past and present, and acknowledge that sovereignty was never ceded, and we are beneficiaries of stolen land and dispossession that began over 200 years ago and continues today. So I've got a few things to talk about today. I'm going to have a little bit to say about talking about abortion and contraception, and I know that Hector's covered this a little bit. I'll talk a bit about abortion data in Victoria and what we know about abortion prevalence and rates, a little bit about 1800 My Options and how we can support you in your practice, whether it's primary care or community health or elsewhere, about the pathways, as Hector has said, in the Northwest Metro region, and a little bit more about what support exists out there. So just to start, I think it's really important to acknowledge, as Hector said, that these are values-based conversations that we're having when we're talking about abortion. And it's really important to consider and understand where we sit with our values relating to abortion care and abortion access. We've spoken already about how abortion is a really essential part of the healthcare system and an important part of the sexual and reproductive healthcare system more broadly, something that people experience and need throughout the continuum of their reproductive lives. We speak to people at 1800 My Options relating to pregnancies for people who are as young as 12 and as old as in their late 50s. And so you never know at what point somebody is going to need to access an abortion service, but it's important that we are coming into these conversations with an open mind and non-judgmental mind and approaching it from a pro-choice perspective, because this is really something that that pregnant person needs to choose for themselves. It's also important to remember that within our own personal values, sometimes we're uncomfortable talking about some of these issues. And so external referral is really, really appropriate if this is not the care that you can be providing. I've put a few points down the right-hand side of this slide as well, because I think it's important to remember how much language can impact people. We speak to many people on the 1800 My Options phone line who've been distressed by the care that they've received within the health system. And so we really encourage you to consider talking about the pregnant person rather than referring to somebody as a mother or as a father. Talking about the pregnancy partner instead of referring to their husband or their boyfriend. Referring to the pregnancy rather than the baby, for example. We use language like abortion at a particular gestation. So it might be abortion at 6 weeks, it might be abortion at 14 weeks, abortion at 24 weeks, rather than saying early or late abortion. We also think about the language that we use when we're talking about prevention, because sometimes we're talking about preventing or reducing unplanned pregnancies, but this can also be stigmatizing as well, because we know that no contraception is 100% effective. We also are really careful about how we talk about the pregnancy itself, because it might be unintended or unplanned or unwanted, but people do have abortions for wanted pregnancies. People are sometimes really happy with an unintended or unplanned pregnancy, and so we just need to be careful about the language that we're using in this space. We don't talk about pro-life when we're talking about people who don't agree with abortion. We talk about anti-choice or anti-abortion people, because it's not necessarily a pro-life approach. So as we've said a couple of times already, it is really common. About 1 in 3 women worldwide will have an abortion at some point in their life, and about 1 in 4 Australian women have had an abortion. We've also got some really interesting data relating to medication abortion. So in 2023, we know that there were just over 10,000 PBS-funded medication abortions received by people living in Victoria. Very similar number were prescribed from practitioners from within abortion. Obviously, this is excluding the non-PBS prescriptions for people who don't have Medicare or who receive the prescription off-label. And it's a rate of about 5.92 women of reproductive age having an abortion in Victoria. The rates for Western Metro, about 6.5 per 1,000 women of reproductive age. For Northern Metro Melbourne, it's about 5.2 per 1,000 women of reproductive age. We can talk a little bit in a bit about some of the differences and discrepancies between regions. So this is a map. So as I said, 1800 My Options is a service of Women's Health Victoria, and this map is one of Women's Health Victoria's other services called the Victorian Women's Health Atlas. And what we have done on the atlas is we have mapped medication abortion figures. We've got the number of medication abortions for LGAs as well as the rate of medication abortion for LGAs. And these numbers are mapped by patient location, by prescriber location, and by pharmacy location. So what the maps I'm showing you here is the one on the left is showing the rate per 1,000 women of reproductive age in 2023 by LGA. And so what you can see there is that the rates across Metro Melbourne are really, really consistent between LGAs. There's higher rates in some LGAs, but generally all across Melbourne, it's blue. People are accessing medication abortion at really, really consistent rates. But on the right, what we're showing is the rate per 1,000 women of reproductive age by prescriber location. And this is where the differences are really, really stark. You can see across much of Metro Melbourne, there are areas where the rates of prescribing are very, very low, despite the demand, which is consistent. And so what this is meaning is that women and pregnant people are needing to travel to be able to access this really basic and essential care. We often talk about people needing to travel from rural Victoria or between areas in rural Victoria when they're accessing abortion services, but the but this is also true for people living in Metro Melbourne. And this kind of travel requirement is particularly difficult for people who don't drive. So that could be young people or people who are unable to drive because of disability or medical reasons. For people who have caring responsibilities, it can be very difficult to be able to travel several suburbs away to be able to access a doctor who is willing to prescribe this medication. So this is where 1800 My Options comes in, because we are here to support people to access services. We are a phone line, we have a web chat, and we have a website. And the phone line and web chat is open 9 to 5, Monday to Friday. We're anonymous and confidential, and we're pro-choice. So we don't make the choice for somebody, we allow them to make it, and we give them capacity to be able to navigate to the services that they need. We support the general public. We have a lot of people who are pregnant or their partners calling us, but we also speak to GPs, nurses, social workers, support workers, teachers, carers of people who are pregnant who are looking for services. We are non-clinical, so we're not providing the counselling and we're not providing the abortion services, but we're providing the navigation to those. And we also make sure that we're non-preferential. So when somebody calls looking for a medication abortion in Footscray, we'll make sure that we give them at least 3 clinics so that they can have enough clinics to reach out to be able to get their needs met. There's no point just giving them one if that clinic doesn't have any appointments available at the time. Our website also has evidence-based sexual and reproductive health information, as well as a database of sexual and reproductive health service providers. It's mapped and people can filter for the services that they need. We've got over 800 services across Victoria registered on our map. Some of them are visible publicly, so you can see them via our website, and some are only visible to our phone line workers and provided to our callers as required. So when somebody calls, we do a basic and brief assessment with them. A few essential questions are around age, Medicare card status, where somebody lives. We'll talk about what services they're looking for. Often when someone's calling about abortion, they're not quite sure which type of abortion is right for them or which might be suitable. We'll also talk about other information that might impact their access. So we'll talk to them about their financial capacity to pay, talk to them about whether they're experiencing any violence or controlling behaviour in their lives, talk to them about whether they're struggling to travel places, for example, and give them those pathways to 3 services. We also importantly have some warm referral pathways for specialist services for people who are experiencing very significant disadvantage or barriers to access. So in last year, we published a report analysing the first 30,000 callers, or just over that, to 1800 My Options to have a look at who is needing support to navigate the service system. And what it showed us is that almost 90% of our callers are looking for abortion services. Basically, they don't know how to access this service in their local area. The majority are aged between 15 to 44, but as I said, the callers' ages do range quite significantly. About 3% of our callers are First Nations and about 40% were born overseas. What's really interesting here is that almost half of our callers have a healthcare card or pension card, and that's compared to about 6% of Victorian females. So we're definitely speaking to people who are experiencing disadvantaged, and only 16% of our callers have health insurance, private health insurance, compared to about 60% of the Australian population. Now, this is mapping. It's a heat map to show where a lot of our callers are coming from. And I think particularly relevant to this Western region discussion is that Melton figure. Melton is where we get most of our calls from, or where we did between 2018 and 2023. It's the highest call rate for all of Victoria, closely followed by some of the other areas in the west, like Hume and Wyndham. So we do get a lot of calls from people from the Western region of Melbourne because the services can be really difficult to navigate. We also, when we talk to our callers, talk about the barriers that they're experiencing, as I said. So from that report that I spoke about you can see that just over 25% of our callers were saying they had financial insecurity that meant they couldn't afford their care. In 2024, that increased significantly to almost 40% of our callers. And so that's a statewide total, and it does vary significantly between different parts of the state. We know that there are some LGAs in the Western Metro region where 60+% of our callers say they cannot afford to pay for an abortion service. Another really interesting part of this data is that callers reaching out to us over 9 weeks gestation were more likely to be coming from specific population groups. So people under 18 years old were about 38% more likely to be calling us over 9 weeks than those who are over 18. People born overseas were about 10% more likely to call us over 9 weeks gestation than those born in Australia. And people from high disadvantaged metro regions were about 17% more likely to call us over 9 weeks than those from low disadvantaged metro Victoria. And people from rural Victoria were 200 to 300% more likely to call us over 9 weeks gestation than someone living in a less disadvantaged metro area. What you can see from this is that we know already that young people under 18 find it more difficult to access health services for a variety of reasons, including health literacy, cost, and ability to actually travel. But what this is really talking to is the fact that a lot of people who really need services are finding it very difficult to navigate the system, and it's getting to a point for them where they are becoming quite limited with their access. So it's becoming more difficult for them to access abortion services beyond 9 weeks. And that's when they're first reaching out to us. So when we speak to our callers, we'll often ask them whether they've spoken to a GP before. And when we ask them that, more than half of our callers have actually spoken to a GP. But only about a quarter of those callers have actually had enough workup from their GP to be able to get, for example, access a service within a public hospital. So it's really important when somebody approaches you talking about a need for abortion that you speak to them about what it is that they're looking for right now. Counselling is something that some people need. So currently we're talking to about 730 or so callers a month right now, and about 3.5% of our callers, so a very small number, are actually wanting pregnancy options counselling. Many of those are not actually looking for support around making a decision. They're more looking at support to come to terms with the decision that they know is right for them. So if somebody's looking for counselling, what they're going to need is, if it's not something that can be done within the clinic, they're going to need some support for a referral to pregnancy option support counselling. It's really important when you're referring patients to a counsellor for this service that you make sure that they are actually pro-choice. There are a lot of services out there, including a lot of phone lines that purport to be dedicated to counselling around decision-making for pregnancy options, but they are actually not pro-choice, and they try to convince people to continue the pregnancy. So considering who is appropriate to make that referral to is really important. Obviously, an ultrasound is often important, and even though someone might not be sure about what they want, it doesn't hurt to give them a referral for that, because it can be really difficult to access these services. Pathology, hospital referrals are really important. As Ekta said, you can look on the website of a hospital, but you can also look at the statewide referral criteria and health pathways, of course, to see what's required for somebody to access a specific hospital. And obviously gynae referrals as appropriate. Now again, 1-800 My Options, we have this map of sexual and reproductive health care providers. You can look on the map and filter for hospitals, GP services, community health, find out who can provide medication abortion, surgical abortion, etc., to be able to be making appropriate referrals. Or you can just give us a call. You can call us with the patient in the room, or with them not in the room, to get some help with that. Now, in terms of access to abortion care, it's complicated. There are different pathways and different criteria and different gestation limits for different services across Victoria. So here I'm highlighting the services that are most relevant to Northwest Melbourne kind of area. ECTA's already spoken to the Women's Hospital in the Northern and the Western, but we do also have the Austin and some private services as well. They've all got different gestation limits, and you can also see that they also have different priority criteria or catchments that might apply. Some of them do require the workup of an ultrasound and blood test, and some do require a GP referral as well. So it's important that people are equipped with that and also with the results of tests, as ECTA said, so that they can access the services in a timely way. We have spoken to many people who have been to multiple GPs trying to get this kind of service and support and had their access to care delayed quite significantly because it's not really well understood how a patient is going to be able to access the services. So it might not be understood that an ultrasound is going to be essential to have an abortion within a public hospital. It's not something that will happen on the day when someone goes in for their appointment. So again, when you talk to your patients, you can provide the appropriate workup and referrals, but give us a call. We can help you to find ways for your patients to access care. One of the things that we also do quite regularly with most of the public hospitals in the state and the private providers is keep an eye on the wait times between different services. So if we are speaking to somebody who is, for example, 14 weeks gestation, and we know that their local hospital only goes to 14 weeks, obviously that's not going to be an appropriate service. But if we know that the next nearest hospital goes to 16 weeks but has a 3-week wait, then we'd be able to provide some information about what would be an appropriate referral for that person. You can also encourage your patients to give us a call. We can give them more information about what they're looking for and alternative pathways if what they're looking for isn't really accessible. But we also really encourage you to consider upskilling in abortion care and contraception care to be able to meet your patients' needs. There are very few things that our callers get excited about on the phone, but one of the things they get really excited about is when we say to them, actually, there's a GP down the road that can help you with a medication abortion. And this is the clinic that they work at. And that patient, and when that caller says, oh my goodness, that's my clinic, I can go to my regular GP to talk about this, you can hear the absolute relief in their voice. We'd also really encourage you, if you do provide any sexual and reproductive healthcare services, whether that is abortion care or contraception or anything else, to register with 1-800-MY-OPTIONS via our website. The registration can be publicly visible or private, as I said, and that can help us to be able to provide your information to people as appropriate and make sure that people are able to access care in a timely manner. So that's me. I'm going to just really briefly flag that there are a lot of supports available for people who are interested in exploring sexual and reproductive health care and abortion care in particular. The AusCAPS Network Community of Practice is a really important one. It's led by the Sphere Coalition over at Monash University. There is a QR code here where you can scan to join. So anyone who is a GP, nurse, midwife, pharmacist, and is registered with AHPRA is able to join Sphere and have a look at a lot of resources. There's opportunities and forums to discuss case studies, to ask questions, and to get some really good information. There are also, I'm going to point out, as ECTA did, some really fabulous resources through the Royal Women's Hospital, guidelines included, as well as some training resources that the Women's Hospital has developed that are hosted on the Women's Health Victoria website. So I'm going to stop sharing now so that we can get to the Q&A that's been put through.
Great. Thank you, Edgar and Carolyn, for wonderful presentations. It's been really great and prompted lots of questions here. So first question, and I just need to tell everybody that the session is recorded and Yvonne will send you a link to it in a week or so. So there's been a few questions about that. So that's all good. So is MTOP safe for transgender person assigned female at birth? Etka?
Look, that's a really good question. Yes. If biologically they are able to get pregnant, there is nothing that would be precluding them from a medical abortion. I think the only thing I would talk to them about is that expectation of pain and bleeding. So whether or not they were having regular periods leading up to this, if they've been amenorrheic for a couple of years, if they're on testosterone and things, they might not be used to a period. And one of the biggest things with early medical abortion is patients complain about the pain, but more so that they weren't expecting it. And so if they have appropriate counseling beforehand and they're aware of what to expect and the bleeding and whether that might cause any dysphoria. So no, there is no medical reason not to do that. I think it just involves, a really open discussion of what to expect, and not really saying you'll be fine, with the option of having a surgical instead if they would rather, go to sleep and then just wake up. So I hope that answers that question.
Right, thank you. Next one's a little case. Patient who has irregular periods from polycystic ovaries and tested positive on a home beta-HCG a few times. She wanted an abortion. The beta-HCG was 17 and the ultrasound is pending. Does the beta-HCG exclude an ectopic because it's so low? There's no PV bleeding or abdominal pain, just some bloating and minor back pain, not requiring analgesia.
So what I would say to that from a gynae perspective is if the beta-HCG is only 17, it's a very early pregnancy. I'm actually kind of surprised that their urine was even positive because often the urine doesn't get positive until a beta-HCG of 25. So in that case, I would actually just repeat the beta-HCG 48 hours later, because we know in a normally progressing pregnancy, a beta-HCG should double roughly in 48 hours. My concerns with this is the beta-HCG actually dropping and the pregnancy is non-viable anyways. A couple of other things in that stem there, I wouldn't bother doing an ultrasound. An ultrasound with a beta-HCG of less than actually 1,500, but definitely less than 1,000 will not show an intrauterine pregnancy unless they have signs of symptoms of an ectopic and you're concerned about that. But if it's just to locate the pregnancy for an abortion, at a beta-HCG of 17, you won't see anything. It also doesn't exclude an ectopic because the beta is low. What would be more informative is that beta rising appropriately or not? And if it's not doubling in 48 hours, then I would be suspicious that it's not a normal pregnancy and probably refer to an early pregnancy service, or even then get a scan because it's not progressing, it's not increasing normally.
Right, thank you. Now another question, do you screen all patients for domestic violence when they request termination of pregnancy?
Yeah, so I am fortunate to work in public services where I have an excellent nursing and social work team. And so I do acknowledge the difference in my practice in that regard. But we use the MERIM tool and all patients are screened for family violence and provided with resources.
Mm-hmm. So we might put that tool in our resources. Yep. All right, thank you. Somebody's commented, I would feel more confident if there was a mentor or a senior who will help me guide me through it initially. So, Etka, is that something that perhaps our nurses, if somebody called in, would handhold, or are we better through the Women's Health Club?
OzCaps actually would probably be the right network to reach out there and maybe even just see if you can link in with a mentor who would be someone that you would be able to. MS two-step, which was Mari Stopes, previously when you had to be certified, they actually provided an online course for it. So you do have to register through their website, but they still do have resources available as well. If you wanted to do some kind of online training and get some more information about that as well. And the women's has really good pathways as well. But in terms of having a specific mentor, I think linking in with another GP through OzCaps would probably be the best thing.
Great, thank you. With the medical termination, how bad is the pain compared to labour pain?
How long is a piece of string?
Mm.
It's so variable. It's usually described, look, every woman is different, and every or pregnant person, and everyone's experience is different as well. Generally, it's described as a very, very bad period. So not generally to the extent of labor, but much more than a bad period. Interestingly, I cannot quote the exact paper, but a study was done, I remember hearing about it a couple of years ago, where women who have severe dysmenorrhea or really painful periods actually find an MTOP more painful as well. So that might just be something to explore with the patient, that if their periods are very painful and they find them very painful, they will probably have more perceived pain with the medical abortion as well.
Okay. And what do you use for the pain?
Interestingly, and actually the new RAMSCA guidelines have said this, they have actually recommended 1,600 milligrams of ibuprofen stat. That was supported by a paper, a contraception paper in either 2020 or 2022, and it is endorsed in the RAMSCA guidelines. We're just finalizing the Western Health abortion guidelines, and our pharmacy has endorsed that as well now. So it's just a one-off dose. Followed by 400 to 600, 6 to 8 hours later. And that was found to be as effective as opiates and actually reduce the opiate requirement. I do provide women with oxycodone to go home with, only 5 tablets, 5 milligram, 5 tablets, because that pain can be very intense in that first day. Codeine would be an alternative, but if they've already taken Panadol, then they can't take Panadine Forte. And so that's why I generally would give some oxycodone, but I would have that conversation with the patient and do the high dose of NSAIDs.
Great, thank you. And how soon after an MTOP can somebody have an IUD inserted?
Look, generally, once the pregnancy has been expelled or passed, so I would usually say after that 2 to 3 week mark, if that beta HCG has fallen appropriately, so by 80%, and their bleeding has settled.
Great. And if you're not inserting IUDs yourself, then there is an IUD clinic up at Bacchus Marsh, and the Women's Health Hub, I think they're doing them there as well.
And if you go on to 1-800-MY-OPTION, there will be a list of local providers for you as well. Implanon and Depo-Provera can be given on the day of mifepristone. So if a patient does want an Implanon, you can do that on the day you see them in that first consult. You can do it at their follow-up as well if you're their regular GP and they will come back to you. But you can do contraception. And if they're on the pill, they can start that the day after Miso as well.
Thank you. And I think there's just a question that's popped up in the chat. Somebody said, just to refer back to the beta HCG as 17, if it's doubling, when will we do that ultrasound and proceed to MTOP?
So if the beta HCG is doubling appropriately, I would probably do 48 hours and another 48 hours later just to check. And then I would book, so the beta HCG should double every 48 hours. And you won't see an intrauterine pregnancy on a transvaginal scan until that beta HCG is about 1500. So I can't do the maths that quickly enough, but it would probably be 7 to 10 days before that beta HCG is even at a level to bother doing an ultrasound. I would only scan them sooner if I was worried about an ectopic pregnancy in that regard.
Good. Great. Thank you. I think
there was
there's one more question that's just popped up. Yeah, I've just scrolled down. Does the high dose anti-inflammatories have higher side effect rate? What do I need to tell patients to look out for?
Yeah, look, nothing, I haven't used it enough to have patients report side effects to me. The papers that have published it, it's just a single dose, so it's unlikely to. The other part of this is misoprostol is actually protective against gastric ulcers. That's how misoprostol came to be in the first place. They used it for the treatment of gastric ulcers and found that women were miscarrying pregnancies. So giving it concurrently with the misoprostol will actually be protective. I would also encourage patients to take it with food to try and reduce any GI upset. When I'm prescribing an MTOP, I also provide a script for an antiemetic. So either metoclopramide or ondansetron.
Right. Thank you very much. I think that's the end of the questions. So there's just important, everybody, if you could just ensure that you provide feedback for the session. So that really helps us to plan these sessions. The recording will be sent out to you, as well as a link to all the resources. Sorry, Edgar, there's just one more question that's popped up. When is misoprostol dose more effective? 24, 36, 48 hours after mifepristone?
They've all found to be effective, but generally I would do at least 36, probably 36 to 48 is what I would generally suggest.
Right. Thank you. All right. So thank you very much, Carolyn and Edgar, for your fantastic presentations. We really appreciate the time you put in. So, and thanks everyone for attending. If anybody wanted to have a look at any of the past sessions we've done, Edgar has done a fantastic session on contraception about 18 months ago, and that's available on the PHN YouTube site. And we also had a session that Dr. Elska Posma, our former head of obstetrics, has provided on early pregnancy care. So, you know, if you've got anybody who you're unsure what to do in those early sort of pregnancy visits, then Elska's session is there as well. So additional resources for you. So thank you. You'll receive our email from Emon. So good night, everybody.
Good night.